specialist in reproductive infectious diseases. Dr. Money has a BSc in microbiology, and following her residency in obstetrics and gynecology, she did a fellowship in infectious diseases at the University of Washington. Dr. Money has developed a translational research program in reproductive infectious diseases with a focus on HIV in pregnancy, HPV, and cervical cancer. Dr. Money is leading a human microbiome project to understand the role of the vaginal microbiome in health and disease. And as such, she has published over 170 peer-reviewed publications and received over $24 million in peer-reviewed research awards. Dr. Money has also been honored with many awards, including the YWCA Woman of Distinction Award and the Queen Elizabeth II Diamond Jubilee Medal, and the Women's Health Research Institute Career Award for Excellence in Research. So, Dr. Money, without further ado, we're so excited to hear your talk. Thank you for joining us today, and I'll ask you to go ahead and share your screen.
So Caitlin, thank you so much. You didn't need to go through all that stuff, but anyway, thanks for doing that. Very appreciated. Happy to be here this afternoon, and goodness me, thanks to everybody for hanging in there. You've had a very interesting, but obviously long afternoon. So it's my pleasure to talk a bit about COVID, which seems to be the topic of conversation these days. I'm going to talk a little bit about COVID in pregnancy and talk about the vaccines, and hopefully relevant to this audience, issues around fertility as well. I'd just like to acknowledge I work, live, and play on the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh, and this is the outline, and I don't have any disclosures. So I do want to touch on pregnancy because understanding a bit about the COVID outcomes in pregnancy influence our attitudes towards vaccines and our attitudes towards vaccination in those planning a pregnancy. So we do know from international literature, and I'm just pulling together a whole bunch of papers into essentially one or two slides here to say that we have had evidence from around the world that pregnant women who get SARS-CoV-2 infections definitely experience unfavorable outcomes with higher rates of hospitalization, ICU admission, ventilation, and preterm birth, and in some studies, higher rates of preeclampsia and stillbirth. Obviously the prematurity and other complications are associated with intensive care for these neonates, which is obviously an adverse outcome. Fortunately, this is not one of the viruses that appears to be transplacentally transmitted, but there is a low rate of perinatal transmission that's probably primarily respiratory and environment. So I do want to share the fact that we've had the ability since the beginning of the pandemic to look at Canadian data. So a huge collaborative group from all the provinces and territories came together to try and pull together this pan-Canadian surveillance project. And we've been producing reports for the purposes of public health and clinical care. And we're just now getting into the peer-reviewed manuscript publication because we just wanted to get things out quickly so people could make the best decisions possible. So what have we seen? Well, certainly we have seen a remarkable number of women with SARS-CoV-2 infection in Canada, and this is an underestimate. So we're over 8,000 in mid-October, but Quebec has not been reporting since December, so that will add another 1,000 or two, and Saskatchewan has not had the resources to report. So this is an underestimate, but it's substantive. So we're probably in the ballpark of at least 10,000 SARS-CoV-2 infections in pregnancy in this country. So what we've been able to do to date is we've been able to pull data up to the end of April on nearly 5,000 completed pregnancies from the 6 provinces from which we've been able to get data. I won't bore you with the administrative challenges of getting data across provincial lines, but it has been substantive. And so it's been a work in progress, and we are currently also pulling September data. We also have the advantage that CIHI pulled together their pandemic time period data for us faster than normal. So we had relevant comparisons for pregnancy outcomes for our COVID pregnancies. And we've also used StatCan and Public Health Agency demographics for comparison. So the first thing that I will draw your attention to in Canada is that the burden of COVID in pregnancy is very disproportionate to the general distribution of ethnicity for women in this country. Now, we will get, and we're working on it, getting pregnancy distribution of ethnicity, because we know some subpopulations have slightly different fertility rates. But overall, I think we can note that racialized groups are certainly being overrepresented in people with SARS-CoV-2 infection. And then when we just sort of drill down on a couple of the high points in terms of the pregnancy outcomes, we are consistently throughout all of our analyses seeing an increased rate of hospitalization for COVID. This is not your preeclampsia hospitalization, your abruptions, all those things. It's for a COVID event. I don't know, deny, go away. And the ICU admissions are even more disturbing, where we're seeing higher rates of ICU admission. And although these absolute rates aren't that high, this is significant. And I'm sure you've been seeing in the news or experiencing clinically yourself that in fact, this is a very real experience with surprising and significant numbers of individuals with serious illness in pregnancy. The other thing that I just want to note, and we're going to look at this much better in our next pull of data for more recently, is an uptick in severity as we're moving into phase 4. And that's been certainly reported from the individual provinces, and we're going to pull that data together shortly. The other piece that I think is relevant for counseling for women planning pregnancy in a pandemic period, or pregnant and considering vaccination or not, is outcome for babies. And as we know, women are really rather poor at being troubled about their personal outcomes, but they're very worried about their babies. And so here we're seeing significantly higher rates of prematurity. And we have the pandemic period comparisons here, because we've had a bit of a change in outcomes in pregnancy related to the whole pandemic experience. And so we're seeing about 14% rates of preterm birth, which for Canadian context is high. And that goes all the way down the gestational ages, where of course morbidity gets much, much higher, as you well know, in the lower gestational ages. Stillbirth in our data set was not higher, although has been reported in US and UK data. So we're keeping an eye on that and don't know if it's a numbers game. And I just want to flag for those that have patients that are delivering at BC Women's Hospital, we do have a biorepository study trying to get samples from individuals who've had SARS-CoV-2 to better understand the immune response to this infection at a more cellular level. So I think this is a good example of surveillance data immediately informing decision-making at the public health level. And we were able to report to our public health leadership these rates. And we have our pregnant persons at the rate of about a 55 to a 59-year-old. And you know, we had age stratified prioritization categories in the country. And so this prioritized pregnant persons and really got us to the point that we were actually not only being permissive about vaccination in pregnancy, but advocating for vaccination in pregnancy to prevent adverse outcomes. And the SOGC has come out with a whole series of statements, but are trying to get very kind of blunt, I think would be a fair statement, around offering this vaccination at any time in pregnancy or during breastfeeding, and really recommending it. And there's another version coming out very, very shortly that's just in final edits. So I just want to kind of move to talk about vaccination pregnancy and then talk about the whole query infertility thing and so on. So I think the one thing that's been really troubling is this persistent myth that vaccinations of any kind are problematic in pregnancy. It's been around for decades. It's absolutely not true. There is not a vaccine that has been in use historically that has caused specific problems in pregnancy. And that includes the live attenuated vaccines that we avoid, but in fact, if inadvertently delivered, they are do not result in adverse outcomes. And we have several vaccines, although now really we're looking at the mRNA ones in terms of common circulation. And I just really want to address the fact that this is not a new platform. It's a new vaccine, as a COVID vaccine, but the mRNA platform has actually been around for decades. It's been worked on for several vaccines. Part of the problem is some of the vaccines weren't successful at preventing disease, so they didn't come to market. But Ebola vaccine, CMV vaccine, HIV vaccines, many have been using this very elegant platform. And so there's a few key pieces to this that is important when you're talking to patients. This is a RNA sequence that codes just for the virus spike protein. It goes in a lipid coating, it is injected into the arm, and that lipid coating disappears, and the mRNA enters the local lymph nodes and then becomes just the template for the spike protein. The mRNA is not incorporated, it's just a recipe card. It encodes the information on the spike protein. Spike protein's made by the cellular machinery, and then you have spike protein that is present locally. You then create antibodies locally, as you do with vaccines, and it's the antibodies that circulate. You do not have all this spike protein circulating, you do not have mRNA around. So trying to dispel that myth, I think, is really, really important. There is also the AstraZeneca platform, but we really have not been using that a great deal in this country. It really results in the same thing. It's a modified viral vector, a little bit more conservative, but I think personally a little less elegant. And you end up with spike protein circulating, and the same after that, basically the same mechanisms occur. I'll just spend a second on the thrombosis issue. That much was made of this, particularly associated with AstraZeneca. Extraordinarily rare, unusual mechanism, not the same mechanism by which we're concerned about increasing thrombosis and blood clots in pregnancy. So it's not an additive phenomenon. It's an isolated and rare phenomenon that we're not really seeing in Canada now because we're not using these vaccines much. I want to put this slide in. It's truly hot off the press. This is data from Danuta Skoronsky, who works at BCCDC in collaboration with colleagues in Quebec, where they've looked at population level effectiveness of these vaccines in the Canadian context with our spaced vaccines by age group. And I want to draw your attention to those that are mRNA. This one column is double AstraZeneca, but all the rest are at least one of the two doses are an mRNA. So mixed mRNA or AstraZeneca plus mRNA, and we are in the 90s here. So the kind of, I don't know, brownie is death and the blue is hospitalization. And this is an extraordinary performance for a vaccine, and it holds right the way to the older age group, which I know is not as relevant for fertility, but important for general care. And so extraordinarily effective and lasting for 5 to 7 months so far. So that's the backdrop. And then we have to understand vaccination and pregnancy. Well, although we got, I don't know, I think we all got taught in medical school that pregnant women were immunocompromised. Well, to be honest, pregnant women have a shift in their immune response in order to tolerate fetus, but they're not immunocompromised in the sense that they don't respond with a good antibody response to infections that they encounter. And in fact, make good antibodies as a rule, unless they've got other comorbidities. So they make good antibodies, they circulate those IgGs, and those cross the placenta to the baby and are actually very helpful in providing a bit of a protection for an infant in the newborn period. Now, the other kind of concern is, well, there's no data. Well, yes, it's true that in the licensure trials, there was a deliberate exclusion of pregnant persons, but as with all products and vaccines, we really look to post-licensure when hundreds of thousands of people receive the vaccines to look really at vaccine adverse events reporting, so the VAERS system. So this is data from a subset of the VAERS system in the United States called VSafe. It's a registry. So there's about 160,000 pregnant persons in the United States that have received the COVID vaccine. And this is the original subset analysis on several thousand, looking at pregnancy loss and live birth, preterm birth rates, everything, all very similar to US background rates. So no safety signals whatsoever there. We've got smaller numbers, but spontaneous abortions showing no flags at all, preterm birth, other abnormalities, no congenital anomaly flags, etc. So then in somewhat more recent publication from this same group in mid-October, they looked at particularly trying to focus on the miscarriage question, although no biologic plausibility to assume this, but much concern. And so really looks at this as best they can, recognizing this is a difficult thing to track. And what they've seen is no increase in spontaneous abortion associated with vaccine. And more specifically, and I think probably this audience is better at knowing these kind of numbers all the way down, but really we're seeing very, very low week specific rates of spontaneous abortions in this population who've been vaccinated early on, either just before pregnancy or very early on. And so very comparable, in fact, slightly lower rates perhaps than background. And then we've got some Ontario data. Deshane Fell, who's part of our Can COVID Preg, has also been doing some really interesting work in Ontario. Ontario has something called Born Ontario, which is kind of like PSBC on steroids, where they track real-time perinatal outcomes. And they've added a COVID module for Can COVID Preg, but in this case, they've linked this data to the vaccine registry in Ontario. So they have all the people who've been vaccinated, and they can figure out who's pregnant and look at pregnancy outcomes. So they have nearly 40,000 who've received at least one dose of COVID-19 vaccine. Older gestational ages, I think, related to the timing of when the vaccine rollout happened. And preliminary information here would suggest, in fact, a very low rates of preterm birth, lower than average actually, no increase in small for gestational age. So again, no signals for adverse outcomes. And they're going to continue to follow this over time, which is actually a great surveillance tool. So there's been a lot. I think you will know that the social media is just swirling on all the badness associated with COVID related to reproduction. And there's this rather curious business about Symposium 1 being similar to the SARS-CoV-2 spike protein. In fact, they are not particularly similar at all in structure. And it's not, the spike protein is really only presented to lymph node, to the T cells and lymph nodes to create and B cells in the local area after you get your vaccine in your local lymph nodes to present antibodies. And we are not seeing spike protein circulating. It actually is cleared in usually about 10 days to 2 weeks. And so this is not even a plausible kind of explanation for concern, and no reason to suspect that it would cause placental implantation issues. Other fertility questions have been looked at, and probably the one thing that's kind of curious and appears to be real is that there's a very brief alteration in menstrual cycle in the first cycle or two after vaccination in some individuals. And it's also been reported in other vaccinations, and whether it's related to the stress of getting vaccinated, whether it's related to that kind of that reaction one gets, you know, the feeling of being unwell and a bit of inflammation associated with that, but appears to completely revert to normal shortly thereafter. But no data to suggest that this is associated with an impact on fertility. So unintended pregnancy rates are similar in vaccinated and unvaccinated. In various fertility clinics looking at this, there appears to be no difference. This data from a relatively small study looking at people undergoing frozen embryo transfer, we're seeing that whether you're vaccinated, whether you've had a history of infection, or whether you're not ever been exposed to SARS-CoV-2, pregnancy rates are similar, if anything, a little trend to being better in vaccine, but not statistically significant. But again, no signal whatsoever that there is an impact, a negative impact on outcomes in the context of trying to get pregnant. And this is just yet another trial from the UK looking at the AstraZeneca, which they have used, looked at 3 trials of inadvertent pregnancy in AstraZeneca trials, and found no evidence of reduced fertility in this context. So what we're trying to do is more for a reassurance purpose and to track it in Canada. We've got a registry for people who are pregnant or lactating and want to give us information on their attitudes and their outcomes. We've got just short of 6,000 participants so far, and very, very preliminary data would suggest that there's no signals again of adverse pregnancy outcomes associated with vaccination, at least in those reported to our vaccine registry. So I'm kind of trying to rush through a little bit because I want to get to questions, but I think really that when we looked at all the international data before we could pull our Canadian data, we were seeing persistently concerning adverse outcomes for pregnant persons who got SARS-CoV-2 infection. We've seen this demonstrated in our Canadian data across the provinces. We have therefore been recommending vaccine for women planning a pregnancy, ideally becoming immune before you become pregnant. But if you're in pregnancy, to go ahead and be double vaccinated. And we hope that this community continue to sort of replicate this message in whatever way we can. We're learning that we're not as good as we could be in getting this out in social media and other things, but we're trying our very best to get what we believe is real information out. So I'm happy, Caitlin, to stop there. And if there's time for questions, I just want to recognize a huge number of people across the country involved in this work. So thanks.
All right, thank you so much, Dr. Money. That was a great review of the data and obviously very, very up to date. So we really appreciate you putting all the latest information in that presentation. So somebody had, maybe I'll just start with one question somebody had texted me, which was about the waning antibodies and boosters. Obviously, somebody has seen the announcement today regarding booster shots being available in early 2020, unless you're in the ICU. So how should we be counseling our patients, pregnant or otherwise, about their current antibody status and the need for boosters?
You know, I have to be honest, in a relatively young, otherwise healthy individual, the antibodies appear to be lasting well. I think it's with an abundance of caution. They're adding this booster shot in early 2022 for the regular population. And just as a reminder, I mean, the natural antibody curve is it peaks and wanes. That's what antibodies do after a vaccine. And what we don't know with COVID is if it's going to be more like a hepatitis vaccine where you have really good memory cells and you get an anamnestic response when you see the virus again, or whether or not, because the virus is mutating, we're going to need new boostering. So I would say if a person is in the category that boostering is being offered, I would take it. There's not a harm in it, but I actually, to be honest, I'm not sure how much we really need it.
Okay, and there's a question here. Is there data comparing pregnant people who have received the vaccine versus pregnant people who have had COVID? A lot of my patients in primary care say they would rather do non-vaccine prevention strategies because of the unknowns, and I'd like to be able to better educate them on the risk of vaccine versus risk of infection.
So I didn't really put it up quite side by side in the slides, but we absolutely know that there are significant adverse outcomes associated with the COVID infection. And with the best of intentions, people who are out and about in the world, most people are having to shop or work or whatever, are being exposed depending a little bit on their circumstances. And everything that we've seen would suggest that that being vaccinated not only protects you, it protects your infant and has no additional adverse pregnancy outcomes. And in fact, there's a trend to a little bit better in our early data.
And I think this question was also getting at, if the patient has already had COVID and they're saying, well, I don't need the vaccine, how would you counsel that patient?
Sorry, I get what you're saying now. what it appears is that natural infection, unless you're quite ill, is not producing a great antibody response, and it doesn't seem to be lasting. So if you look at the natural curves before that, and we did a lot of that before vaccines, or my colleagues did, you really see kind of a really wimpy antibody response and a tail off quite quickly, to the point that actually we're having trouble with our seroepidemiology at about 4 to 6 months, because we can't measure antibody is gone in naturally infected people, whereas it's holding quite high in vaccine. It's just a better immune stimulant. And I would say get vaccinated regardless.
Okay. There's a question here about, is there any data on protection for babies after birth from the maternal vaccination during pregnancy? So those IgG antibodies that we believe are being passed along, do we have any data about how much or how long that protection is effective?
So that data is coming in, but so we have both COVID data and we have kind of translatable data from things like pertussis. So we deliberately give pertussis for the purposes of immune protection to the baby, right? It's not for mom. And so we know for sure that IgG is a small molecule, it crosses the placenta. And so a little bit dependent on the timing of the vaccination and on the person's immune response themselves, the baby will definitely get antibody. 100% of the babies have some antibody. The level and duration of that we're still looking at, but traditionally passive antibody lasts a good 6 months and in some cases longer. So that really does give that baby a good bubble of protection. What is a bit of a misconception is if you do that vaccination in breastfeeding, there is some excretion of the antibody in breast milk, but that's then orally ingested. And there's very poor data on the level of antibody in the infant's bloodstream from orally ingested milk antibody.
Okay. And then a question about, is there evidence that you would spread out the doses for patients who have not yet received the vaccine based on the UK experience of antibody production when the doses were spread 8 to 12 weeks apart? So what would you recommend?
So the current recommendation, just recently reviewed last week and published by NACI, and I know we've had some challenges with NACI, but we're going with 8 weeks. So when we look at the data from the sort of the 3 to 4 week interval, which was the recommended interval from the companies, and then we look at our 8 to 12 week intervals that has been kind of the natural experiment in Canada, the SOF is about 8 weeks in terms of benefit, in terms of getting a better boost. So you definitely get a better boost, and the Canadian data shows that very nicely with that slightly longer spread, so about 8 weeks.
Okay, and I'm actively typing here because there is a question from Dr. Sai, but I cannot see the question. Do you want to retype that? Somebody said thank you with 2 exclamation marks. So I think Brian will probably.
There's a Brian Say asking about preprint data from Israel. Is that the one you were wondering about?
Oh yes, thank you.
Yeah, I can read it. It appears.
Okay, there, now I see it. Yeah.
Yeah, you know, I think we've got every country is giving us different data from different situations. But what I would say from our Canadian data, and we've got, I've got the privilege of being on the immunity task force, so I get quite a bit of stuff presented to us every few weeks. There is definitely an antibody response, but it is definitely not as robust and not as durable in natural infection when compared to vaccine-induced immunity. And that's pretty consistent around the world. So there'll be the odd study that'll show something slightly different, but if you look at kind of everything as a whole, I think that's pretty consistent everywhere, including here.
Okay. Wonderful. So if any other questions pop up, I will let you answer those in the chat. Thank you very much again for your presentation, and thank you to everybody for coming. I think that was about over 250 attendees during the day, which is a record for us here at our 5th annual Fertility and Reproductive Medicine Symposium. You will all get, with the address that you registered with, our swag this year has to be lightweight because it has to be mailed out. So it's this lunch bag here. I have been beta testing it for you, and I can verify it works quite well. And I will just share one more time where we will be posting the slides. So if you're up here and you go physician resources, then all of the information will be under annual fertility symposium. And your CME certificates as well as your swag will be mailed and emailed out in the coming weeks. And unless anybody has any more questions that they want to pop in the Zoom box there, I think that will conclude our 5th annual symposium.
Thanks, Caitlin.